Please make sure that your questions are respectful. Please be mindful of how much time you're taking if you're participating in the chat or the podcast. If you do have any questions for the panelists or for me as or Dr. Newby Alexander as moderators and technical assistants, please go, submit them through the Q&A and include whether or not your question is directed to a particular panelist. Please keep all your questions and comments short and on topic, and avoid profanity or inappropriate comments. If you are being inappropriate or uncivil, I will kick you out. And if you are having technical issues hearing or seeing anything, please exit the webinar, completely close your browser, and then re-enter the webinar. This is being recorded. I just turned on the recording. So please be aware of that as well. Thank you.
Thank you, Dr. Richmond. Now it is my privilege to introduce you once again.
I can only hear you by phone. I cannot hear you on the...
Now it is my privilege once again to introduce you to our esteemed moderator and series collaborator who will guide you through today's exciting discussion filled with practical and actionable information on the past and the way forward in health here in Hampton Roads. Dr. Cassandra Newby Alexander is the endowed professor of Virginia Black History and Culture. She is also the emeritus director of the Joseph Jenkins Roberts Center for African Diaspora Studies at Norfolk University. Dr. Newby Alexander has received numerous awards and commendations, including the William M.E. Rishal Award for the Best Overall Article for her 2018 article on Sarah Garland Jones in the Virginia Magazine of History and Biography. She's won Distinguished Service Awards. She's won an award from the Humanitarian Award from the Virginia Center for Inclusive Communities, and she is a celebrated author and editor with some of her notable publications, including Virginia Waterways and the Underground Railroad and an African American history of the Civil War in Hampton Roads, to name a few. Ladies and gentlemen, please welcome today's moderator, Dr. Cassandra Newby Alexander.
Thank you so much, Hillary, for that kind introduction, and welcome everyone to this panel, which I believe is going to be an exciting one today. And so, Stephanie, if you could take us to the next slide. I want to really give everybody a little bit of a history or historical overview of healthcare, and especially as it applies to Hampton Roads. Well, you know, many African Americans have experienced generations of inadequate or non-existent healthcare. This made worse by the refusal of Southern health institutions and, of course, red states to provide healthcare, especially government-funded healthcare, to their population. And this, of course, is disproportionately impacting African Americans. The results of a lot of these inequities historically have been that African Americans have suffered disease and sickness at a much higher rate than the rest of the population. In addition to that, long-standing not only enslavement, but segregation, discrimination in housing, in the ways that neighborhoods are maintained, as well as poor health care and discriminatory health care have resulted in so many African Americans being ill-nourished, or in the case that we know of recently of contaminated water, city sewer and sanitation systems, contaminated land, lack of canopy, meaning that there are hotter temperatures in areas. So much of this also resulted from redlining, which of course has condemned Black communities to a higher rate of infections for highly contagious diseases, as well as, of course, issues today. We have COVID and monkeypox being a really big issue today in a lot of African American communities still. In the past, we would see tuberculosis.
Can you hear me now?
We would see tuberculosis. We would have pneumonia, syphilis, hookworm, pellagra, which was a 19th century disease that had to do with a lot of a virus within the soil. So histories have illustrated this poor and inadequate and discriminatory, in some cases, even inhumane healthcare provided to African Americans. Current studies continue to highlight these disparities and the institutionalized marginalization of African Americans is seen in their poor health conditions. And yet, African Americans have carried medical knowledge and practices with them to the Americas from the continent of Africa and were an important source for their survival and well-being. And this really brings us to my first point about enslaved healers, slave clinics, et cetera, et cetera. We know from the ex-slave interviews that were conducted in the 1930s and 40s by the Works Progress Administration, known as the WPA, that inventoried many of the herbal, plant, and non-plant remedies that were used by African American folk practitioners during slavery. These accounts demonstrated there was a symbiotic relationship between folk remedies, and faith in the healing process. Moreover, we would see referenced plant or herbal remedies that have been proven to have a positive impact on the health and well-being of people. For example, cure a nosebleed by holding a silver quarter on the back of the neck, treat an earache with sweet oil drops, wear plant roots to keep from catching colds. Some of these, of course, are not really relevant, but some of them have some medicinal purposes and remedies. Within many African American families today, they continue some of these practices because they've been woven into the fabric of Black culture, often communicated through women. These folk practices then shaped the concepts about healing that are diffused through African American communities. So some people may know these through faith healing or making a mojo by using herbs, charms, and rituals to heal. What is important is to recognize that there is this ongoing link in many African American communities between these healing practices and expressions of faith, often not recognized by the medical communities. What's also interesting is that sometimes, and this was during the slavery period, so we're talking about from the 17th through the Civil War, the 1865, that some of these enslaved healers were identified also with freedom seeking, with inspiring revolutions, and that they were using these herbs and diviners, they were using these early nurses and midwives to help not only expose the community to how they can heal themselves, but also spreading word about freedom and how they can become free. At the same time that they were doing that, they really showed themselves to be an essential part of Southern life and the emergence of medical ideas. And one thing that most people don't realize is that modern medicine really did not begin until the latter part of the 19th century. We see in the records of the Civil War that most physicians, white physicians, were still practicing medicines from the centuries ago in Europe. They still believe, for example, and you would see this in some of the medical reports during the Civil War, especially the early part of the Civil War, they would advise soldiers not to drink water after a hard march. Instead, they should drink alcohol. And of course, we know alcohol makes you even thirstier, and of course, you'd be more dehydrated. So modern medicine was birthed out of this huge war. And many African American practitioners already knew that many of these practices just did not work. And so many African Americans in some ways survived better with their folk medicine practices than using the medicine of that era. But by the time we get into the latter part of the 19th century, we would begin to see African Americans becoming trained physicians. We would see them becoming trained nurses and trained midwives, and they would begin to help address the healthcare disparities that were just so significant in the Black communities. But of course, they were small in numbers. The healthcare professionals who would assist by 1890 there were only a little over 900 Black physicians in the United States, serving a population of Blacks of over 7.5 million. The American Medical Association emerged in 1895 to help not only get African American physicians talking with each other and sharing their experiences and their techniques, but also promoting the emergence of more Black physicians, encouraging more of that. In Hampton Roads, two of the presidents of the National Medical Association, Dr. David Byrd and Dr. Francis, they were both physicians here practicing who spread that knowledge. And as a result of their involvement, we would see the emergence, as we would see throughout the nation, of a privately owned Black hospital that would later be known as Norfolk Community Hospital. We would see the success of the growth of Black physicians by the early part of the 20th century, with even 70 women by 1903 serving as physicians. In fact, Sarah Garland Jones from Richmond became the first African American woman in Virginia licensed to practice medicine, and she was licensed in 1896. And so these kind of advancements were going on significantly. Next slide, please. Throughout the South, we would start to see, as I said, hospitals emerging, all of them, with the exception of two, were privately owned. The first hospital, of course, that was created was Provident Hospital in Chicago. We would see the Freedmen's Hospital that was part of Howard University emerge. And we would have a physician / historian named Harry Dowling begin to document so much of this important history and how it evolved. By 1900, we would see 40 Black hospitals and 11 Black medical schools in the nation. But because there was an effort by the American Medical Association to reduce the number of Black hospitals, Black medical schools, and Black practitioners, there was an actual assault made by them because they saw Black patients as an important source of income for them, as their ratio between white physicians and white patients began to lower. They then began actively to stop the expansion of Black physicians and Black hospitals and medical schools, so much so that by 1916, there were only 3 Black medical schools left in the country. That was Howard, Meharry, and Leonard Medical School. And Leonard was a part of Shaw University. And because of the requirements, we would see medical schools organized. These were white medical schools organized and create a national organization. Leonard Medical School just could not economically keep up. And so they had to shut their doors by 1918. And so then you only had 2 Black medical schools in the country, and those 2 still exist. And that's at Howard and Meharry. And they're responsible for training the overwhelming number of Black physicians through the 1970s. And so this kind of emphasis on Blacks becoming practitioners as well as becoming specialists was really spearheaded by the National Medical Association. Of course, the big problem was what hospitals would open their doors to African Americans to specialize in medicine. Well, that was a problem. What hospitals would open their doors to Black nurses becoming not only professional nurses, but also becoming advanced, so eventually becoming nurse practitioners? What institutions were open to help midwifery? And so we would really see Black hospitals and Black organizations really starting to assist in developing the professional qualifications and training of those individuals, because for those white hospitals that would train Black nurses, their only purpose was to provide patient care to Black patients in those hospitals who were usually placed either in the attic, basement, or in a general separate ward where they would put men and women in the same ward. They would not do this for the white patients, but they would do this for their Black patients. We would continue to see these kinds of disparities until the real end. It really wasn't until the latter part of the 1960s, the real end of segregated practices. And this is especially in the South, but we would see it also in some places in the North and in the Midwest, as well as the West, these segregated practices or disparaging practices towards African Americans. Major changes, though, we would see in the healthcare system that would result in the closure of the majority of Black hospitals. By early 1950, there were 500 Black-owned hospitals in the nation. By the 1990s, there were 3. And so much of this had to do with changes in the healthcare structure and organization, because as we started to see the emergence by the early 1980s of corporate healthcare industries, Centera and so forth, we would begin to see the demise of so many privately owned hospitals, especially Black hospitals, simply because they could not compete. They were usually nonprofit hospitals. They simply could not compete with these for-profit or not-for-profit corporate medical systems. And as a result, for example, major changes to this healthcare system, as well as to the insurance reimbursements for Medicare and Medicaid. We would see the closing of Newport News General Hospital, which was started as a Black-owned hospital. They would close in 1997. And of course, Norfolk Community Hospital would close just a few years later. Today, we only have, and this is only because they're in partnership with Bon Secours, we have Richmond Community Hospital that still exists, and we have Houston Community Hospital that still exists. And so this is just some of the background, historical background that I wanted all of you to understand about healthcare and health practices. The one thing that I didn't mention earlier was that in the South, and especially in cities like Norfolk and Richmond, you would see the emergence of what they call slave hospitals. And this was when slave owners recognized that they really needed to provide some health care to African Americans, because what we would see written by these white physicians about Blacks was that they were systemically ill, that somehow they didn't need health care because it would not help them. We would see then hospitals and medical schools, such as the Medical College of Virginia, begin experimenting on African Americans. So we would see the evolution, for example, of hysterectomies or C-sections, first practiced on African American women against their will, of course. We would see amputations with and without any kind of anesthesia to see how much pain a person could take, what was the best procedure. And they would do these experimentations on African Americans. In addition to that, we would see cadavers, or in some cases, people killed becoming a cadaver and used by these medical colleges, such as the Medical College of Virginia in Richmond. We would see them using Black bodies to experiment on to benefit the white population. And then the worst, of course, was the Tuskegee experiment, in which so many African American men and women were exposed to syphilis intentionally to see what would be the progress and impact on the bodies of individuals exposed, not just the men who were exposed, but their secondary exposure to women and their wives usually, and the next generation, what impact that had on the children. And this was always done to harm African Americans for the benefit of whites, because they were not seen or regarded fully as human. And so many of these belief systems are still a part of the institutionalized way that African Americans are treated in the medical profession. And this I would say discriminatory and institutionalized perspective is what is something that really needs to be addressed. And we're going to talk a little bit about this as we talk about public health. So it is my pleasure, next slide, Stephanie, it is my pleasure to introduce you to our panelists today, and I'm really excited about this. And one of our panelists is Mrs. Beverly Grayman Rich, who has an MS in nursing and an MS in health administration. She has served numerous roles, leadership roles, nurse leadership roles throughout her nursing career. She, I would say, recently retired, but not really, because as is the case with most professionals, when they retire, they just retire to continue to do what they're doing in another capacity. Her last position, official paid position, I'll put it that way, was as the Clinical Performance Improvement Coordinator and Performance Improvement Manager for the Cape Fear Valley Health System in Fayetteville, North Carolina, where she oversaw clinical performance improvement activities, she was the facilities peer reviewer for the medical staff and a facilitator for root cause analysis, failure mode and effects analysis, and the event response teams. She's a member of the North Carolina Nurses Association and the North Carolina Association of Nurse Leaders, where she served as the secretary and is currently the chair for its Diversity and Inclusion Committee. She's a member of Sigma Theta Tau Nursing Honor Society, the American Cancer Society, Relay for Life, the United Order of Tents, Federation of Tent Nurses, and president of the Fayetteville Area of Tent Nurses. She is also a member of the Alpha Kappa Alpha Sorority Incorporated and the Zeta Phi Omega chapter president. Welcome, Mrs. Beverly Grayman Rich, to our panel. Our next panelist is Mrs. Margie Wilson Cofield, who is a retired English teacher from the Virginia Beach City Public Schools and the Tidewater Community College, where she worked as an adjunct. She's a community leader, so you will see Mrs. Cofield everywhere in this community. And she has worked very hard to preserve African American history, and as a result has made numerous contributions throughout Hampton Roads and the Commonwealth of Virginia, as well as beyond the Commonwealth. Her reach is large. She has, for example, assisted, and I'll talk about some of the projects she's assisted with, but she's assisted so many projects that, you know, her whole philosophy in life is to be a servant leader. She said we should use our talents to help others, and we should work together to make this world a better place for everyone. She has spearheaded many different initiatives, such as serving as chair of the Princess Anne County Training School, Union Kempsville High School, what they call PACS UKHS Museum Committee, and has completed the research and recommended the design of the museum and serves on its board of directors. She has also served as a life member of the VIA Heritage Association, served on the Dr. L.D. Britt Scholarship Committee, and has continued to work very hard with the city of Virginia Beach to make sure that this history is known by all. And our last but not least panelist is my colleague and friend, Dr. Felicia Mebane, who is the Executive Director of the Center for Public Health Initiatives at Norfolk State University. She is the NSU Director for the One School of Public Health Initiative, and she's going to tell us what ONE means. She has earned a bachelor's degree in Science and Business Administration from the University of North Carolina, Chapel Hill, and has developed her leadership and management skills at the GE and AARP. Her public health training, including an SPH from the University of North Carolina, Chapel Hill, PhD from Harvard University, has focused on health policy and communications. She has more than 15 years of experience in higher ed, including academic and leadership positions focused on student success. And before working as a full-time entrepreneur from 2011 to 2017, Dr. Mebane conducted research and taught as an assistant professor at UNC Gilling School of Global Public Health, where she also served as the assistant dean for student affairs. Welcome, Dr. Mebane, to our group. Now for the really interesting part of our webinar. I've got questions for everybody, and then we will have an opportunity for our guests to also ask questions. And when we get to that point, Stephanie Richmond will tell us how you can do that. This question, though, is to Mrs. Cofield. And I wanted to ask her, what kinds of folk remedies did you grow up hearing about and practicing? And did any of those cures really work?
Well, first, can you hear me talking? Okay, first, I would like to say thank you for allowing me to be a member of the panelists today. Good afternoon to everyone. The question about what kinds of folk remedies did you grow up with? I first want to start by saying that folk medicine can be a cultural practice, I think of. People, economical and situations can influence their attitudes. I think about my great-grandparents, my grandmothers, and my parents. I'll give you just a little short history. My great-grandmother, Eleanor Virginia Davis, was born in Prince Williams County in 1861. And this was during the time when the Civil War was going on. Later, she moved to Princess Anne County. My grandmothers were born in Princess Anne County during the latter part of the 1800s. I'm just giving you a little background to show how I know these remedies. My paternal grandmother, Miss Cora Wilson, was born in 1897 in Princess Anne County. My father, Carlos Wilson, 1921 baby, born in Accomack County. Isn't that something, when she went over there to teach? And my mother, Annie Eliza Wiggins Wilson, was born in Princess Anne County. So I learned about many of the folk remedies that they talked about. Didn't know how significant they were when I was younger. One, and I'm sure you've heard of this, castor oil mixed with orange juice. Then springtime, we had what they call a springtime cleaning out. My mother gave us cod liver oil. I had to be about 3 or 4 years old, and I remember grabbing my sister, who was 18 months younger than I. We started running. Mama pulled that castor oil out in orange juice, hiding under the bed, and she had something called a Victrola. You heard of that? Like the early tape record player. And I always wondered, how is it that Mom is able to find us? And keep in mind, I'm 3 or 4, we go to the same place each time. Because I could not even drink orange juice until after I graduated from undergraduate school at St. Augustine University, because I always thought about castor oil. And when we became ill, we got chicken noodle soup. We had a cold. If you ever heard of vapor rub, my parents, my grandparents would put that in hot boiling water. Then we take a towel and put it over our heads, hold it over there, and inhale it to get rid of the stuffiness in our noses or congestions in our chest. Then there were others who put garlic in there. And we also had a situation which they put mint leaves in warm water to help our throats, or ginger and lemon in hot water. We would drink it. And those remedies worked. And then I remember, if your body ever started aching, fill up the bathtub with warm water with Epsom salt. You get in there and when you get out, your muscles felt better. Or you could put your feet in warm water with Epsom salt. And turpentine, it sounds strange, but my grandmother, Miss Cora Wilson, would put drops of turpentine in sugar, and we'd take it, whatever was ailing us. Outside playing in the yard, you ever heard of red bug bites? We playing in the grass, rolling around, coming into scratching all over, and my grandmother would take kerosene, mix it with salt, and rub it on our legs and arms in order so that we would have some type of relief. And the last one, there was so many I had, but the last one on the list would be peroxide, rinsing your mouth out in peroxide. And then my mother, if your ear was aching, she would put someone on a swab and put that down, in your ear. And then she pour it a little bit, then you lean over and let it come out. Those are things that I remember that my grandparents told me, and my mom and my dad. Many of those remedies are even used today. And many of us can share these with our children and our grandchildren so that they can know many of the things that they did. My dentist recently told me, Ms. Cofield, rinse your mouth out in some warm salt water, okay? That's something that still works today. So I thought I would share that with you. Thank you.
Thank you so much. You just took me back to my early days. And of course, so many of those remedies are still practiced, and I still practice a lot of them because they work. Cleaning your system out. Now we use green tea and other things, or a pill to actually clean you out. But those old home remedies worked. So our next question is for Mrs. Grayman Rich, and I wanted to know what kinds of folk practices were part of midwifery. And how did any of those practices change over the past 100 years? Now, right before you answer that question, we have a poll for our audience. And this poll is, if your partner has birthed a child, were you able to access obstetric care with a midwife? And we're going to talk about this after Mrs. Grayman Rich answers this question, this first question about midwifery. And this poll is only going to be up for another 30 seconds. So just click your answer and submit. If you or your partner has birthed a child, were you able to access obstetric care with a midwife? Is it no, I or we were not aware of this? The second one, no, I or we were not able to access it, or yes. And Stephanie, how much time do we have for the people to answer that first question?
Have another 15-20 seconds if Mrs. Grayman Rich wants to start, and I'll cut it off as she's going.
All right, good afternoon again to all of my sisters that are participating. And I want to extend a thank you for allowing me to participate. I want to particularly extend a thank you to Mrs. Cofield. Ms. Cofield and I are both members of the United Order of Tents, and was very excited when she contacted me, and then the contact from the rest of my sisters on this presentation, to Hillary, Stephanie, and the list goes on and on and on. But let me go ahead and answer this question to the best of my ability. Ms. Cofield talked a lot about remedies. And so the first response to that question is, the African-American midwife was the keeper of traditions and was a spiritual ritualist. She held a respected position in her community with privileges just like the pastor. She played a large part in shaping cultural perceptions of motherhood, as well as functioning as an officiant in the rite of passage of becoming a mother. So for the African-American community 100 years ago, this midwife role was an integral and very important part of the community. Just as in the Gullah communities, most things come to us from the South. I grew up in Harlem, New York, and everything Ms. Cofield talked about, I experienced in New York City from my friends who had Southern roots, and my families that have Caribbean roots on both sides. So the midwife was very, 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 very important. She carried valuable information and she passed it on by teaching others how to be midwives. And this succeeded across generations. That did positively impact the social societies then and the family structure. And so I would say that the change has come through the then eradication of the role of the midwife. And with that, her guidance then was somewhat diminished. But we're going to have an opportunity to talk about the midwife in this present day and age, which is absolutely phenomenal. So I hope I answered that question to the best of my ability, and that it meant the need of those questions that were asked.
You absolutely did. Thank you. And before we go to your next follow-up question, Stephanie, what are the results of our first poll?
All right, so our first poll, almost 70% of our audience were not aware of the option of using a midwife. So 10 out of the 15 people who responded. 20% were not able to access care from a midwife, and only 13% used a midwife during their obstetric experience.
That's very interesting. It'd be very interesting to find out how many of these individuals are from Virginia versus North Carolina versus other places. So for those of you who answered that question, just put into the chat or the Q&A whether you are, whether if you answered no, you were not aware, you can tell us whether or not you're from this region or where you're from. That'll give us a good idea. So we see the poll. And let's go to the next question for Mrs. Grayman Rich. I was hoping you could explain the historic and current importance of midwifery, especially for African Americans. And then we're going to invite some of the panelists to weigh in on their different experiences.
Thank you, Dr. Nubi Alexander. So to respond to that question, the historic and current importance of midwives, especially in the African, with and associated with African Americans, the African American midwife was and remains a cultural and social resource throughout, although the numbers of midwives in this particular community have decreased, there still remains a role for the midwife in the African American community and the diversity of this profession. But let me give you a little bit of history, as others have. Not sure if everyone knows that several boards of health, particularly in southern states, passed laws in the early 1900s which prohibited African American midwives from entering, get this, the birth canal, thus significantly decreasing the role. So in other words, it was against the law, and you would be persecuted or prosecuted, excuse me, if you participated in midwifery. Let's fast forward just a little bit. So when you look at the importance of the African American midwife, their role was to protect motherhood, to uplift and empower women and men, and improve maternity care in the communities and across the nation. So they served as pseudo-psychologists, dietitians, loan officers, sex experts, prayer partners, marriage counselors, friends, and sometimes relatives to the women who they serve. So this particular role in the African American community was extremely significant, because they met the needs of that community at that present time. You know, as we talked about very briefly in Dr. Newbie Alexander shared with us, there was limits to physicians. So let's not talk about the physician piece, let's talk about the midwifery piece. Not only did they deliver babies, they were significant practitioners in the African American community. I will share with you that in addition to historic, let's talk about the current importance of, and we just did, of the midwife. One of the very predominant and excellent midwifery schools in North Carolina is in a rural area of North Carolina, which is East Carolina University. They have an excellent, excellent midwifery program that also works in conjunction with the certification of nurse midwives becoming certified to care for neonatal babies. So you see that role is a dual role. But again, that midwife in that community, in private practice, can meet the needs of the community and expand from not just working in a hospital setting, but setting up their own practices in rural areas. And believe it or not, there are several nurse midwives that are certified nurse midwives in the African American community. So again, I hope I answered that question pretty good.
We had a
Yes.
follow-up question in the Q&A. Ms. Tamaya Clark says, I'm hearing about midwives today. How are they different from the ones of yesteryear?
Well, the ones of yesteryear did not have an opportunity to have a formal setting of a formal educational setting. However, their informal educational setting from generation to generation, and for them experimenting on what would work right and what wouldn't work right to heal the community is what they did. They didn't have a lot of rules and regulations so that they could try their best to heal communities as best as they can. In this day and age, our nurse midwives are much more equipped from a knowledge-based, research-based direction to provide care, again, not just in the role of midwife, but to serve as a practitioner, a healthcare practitioner throughout our communities.
Well, I wanted to get not only the panelists, but I would like to get Dr. Richmond and Hillary Plate to kind of weigh in on this whole issue of midwifery and really to kind of talk about it, not only from the perspective of this area, but also in the larger United States community. So, can you all tell us a little bit about your experiences or challenges in the use of a midwife? Mrs. Grayman Rich talked about how, there were efforts, and this is all about the medical, especially the white medical communities, stopping the practice of midwifery because it was an economic issue. If they use midwives, then they would not get the money that they really wanted from really the use of Black bodies. And so can you all speak to some of your experiences? And I'd like all the panelists really to weigh in on this.
Yeah, I'm happy to yield to Dr. Richmond first, since she has a local experience with midwives and doctors here, but I would certainly personally agree there's an economic factor that's still at play. So I'll go after Dr. Richmond.
Sorry, of course, I unmute myself and my dogs decide they're going to bark downstairs. So I had a son 5 years ago here in Hampton Roads and experienced some pretty maybe unsurprising medical discrimination and mistreatment, and I cannot imagine how much worse it must have been for the Black women who were also being treated by the physicians, that I was really not given a choice in who I was able to go to. So Hampton Roads, we all know, right? Centara and EVMS have a real stranglehold on the available physicians in the area, particularly when it comes to any sort of high-risk pregnancy or birth. There is, as of 5 years ago, it might have gotten better in the last 5 years, but I somehow doubt it. There's one high-risk OB practice in the area, and you have to deliver at Norfolk General. When I, found out I was pregnant and started going, and they decided I was high risk simply because I was older, over the age of 35. And I asked about, midwives and unassisted birth and minimally invasive, birth practices. They said, this is not an option, not just for you, but not in the area at all. There was one birthing center, and you had to be cleared by an obstetrician that you were low risk before they would take you. And that birthing center, if I recall, was at DePaul Hospital in Norfolk, which is since closed. So I don't know if the birthing center is still there, but the actual hospital attached to it is closed. So it probably means there's even less options because there's not an emergency room immediately next door. And then I ended up having a really eventful, we'll put it that way, pregnancy. I went into preterm labor around 29 weeks, was dismissed by the medical resident who I saw at my 28, 29 week appointment. And that I was not actually in labor, despite the fact that I was sitting there having contractions. And I was like, but you can see them and they hurt, right? And they were like, oh no, they're Braxton Hicks. And I was like, but sometimes they take my breath away, and they're regular and they're not going away. And they were like, no, you're fine. You don't know what you're talking about. This is your first baby. Go home, get off your feet. Well, on the 30 weeks exactly, my water broke. And I went into actual preterm labor and wound up spending almost a month sitting in the antenatal department at Norfolk General, where I witnessed some really appalling treatment by the nurses and physicians assigned to that unit, of particularly women of color, incarcerated women, and non-English speakers. There was a woman who only spoke Spanish in the room next to mine, who they could not get an interpreter there regularly for her. And so they were having her teenage daughter interpret, and she was clearly experiencing a pretty traumatic miscarriage. And so to think about putting not only her, but also her teenage daughter through that, because they didn't keep an interpreter available for her 24/7. And none of the physicians spoke Spanish. And some of the things I witnessed on that floor were really quite disturbing, and very likely, this was well before the pandemic. You were only allowed one support person if you were actively in labor, and you weren't supposed to have visitors, like too many visitors on the floor, because they were all concerned about, infection and germ control. And so people had to make the choice between if you wanted a doula or a family member present, right, as your comfort person. You couldn't have both. So there's a lot of issues in our local health system, especially around high-risk pregnancies, which are often the women who need the most support during pregnancy and delivery. It's really not a surprise to me that Norfolk General has the highest C-section rate in the region. And many, I was not given a choice whether or not I could have a natural birth or a C-section. They basically just told me, this baby's coming out tomorrow, get ready, right? And you're having a C-section. And so there's a lot, to think about myself as, a very well-educated white woman who's upper middle class, right? If I have all these privileges and this is what I experienced, I know the other women who were on the floor were struggling, and have even less privilege and less authority to speak up for themselves.
Yeah, I feel like there's so much room to go in the, we often in a lot of this work talk about the intersectionality between the challenges that happen for marginalized communities, as well as, where does it intersect with other people, and in the intersection of women's health and Black health are really interesting to me, because there are so many things that we can identify with to a certain degree. And then, as Stephanie said, I was coming at birth from a middle class educated perspective, and had doctors who also, doubt whether or not you know your own body. And if that's the case, coming from my area of privilege, what on earth is happening with people who are regularly discriminated against, people who have some difficulty with or translation needs or economic needs? I think there are ways forward. I love that these panels are talking about not only the challenges we have, but the ways forward. And locally, we have a lot of challenges. My experience is that I was from here, but I had my child in New York. And in my opinion, a lot of the things that I saw were based on economics. It was what as Dr. Richmond said, the insurance companies and or the hospitals often have an influence on what's available in your area and how accessible it is to you. I was fortunate to be on State University insurance in New York when I had my daughter. And so the insurance covered my high-risk birth. They covered my desire to go to a midwife if I wanted, but I was recommended to go to an OBGYN. I did something called hypnobirthing, so it kind of dates back to the communal medical history, when women supported you in a village, and you had multiple women helping you, and the idea that approaching birth from a very natural progression perspective, it's something your body is built to do. It's something you're in, and coming at it from that perspective, as opposed to coming at it from a trauma-based perspective, changes how you approach birth and how you experience pain or pressure. And it teaches you to tune in with your body. I had to go and seek a doctor who was willing to do that with me, but there were plenty of them there. I had a doctor that was a woman that was willing to listen to what I was doing with hypnobirthing, and knew that I wanted a midwife, but that because of my condition couldn't, and referred me to the local hospital, because the hospital in Huntington, Long Island has multiple midwives on staff. The actual hospital keeps midwives contracted on staff to support and work with the OBGYNs that practice there. So when my doctor was not available to me, there was a midwife checking on the rest of us in the ward. There were multilingual people checking on people in the middle of the ward. I was one of 10 moms that went into labor that night, and I stayed in labor for 3 days. I was able to, through hypnosis, have a conversation with my doctor about the critical point when we had to determine that I needed to have it. I could have a C-section, or I could go another 8 hours and still possibly run the risk of a C-section. But the agency that was afforded to me, because the insurance companies and the hospitals supported the practice of midwifery. I think there are examples elsewhere in our country, and there are certainly examples elsewhere in the world, where additional health practitioners are given the respect that they deserve, and people are treated in a way that they're being asked, what do you need? Would you like a midwife? If we don't feel like your case is going to be successful purely with a midwife, maybe we pair you with a surgeon and a midwife. Maybe we pair, I felt like there were options available to me there that are not available to people here. And Dr. Richmond and I delivered our children similar timeframes. My daughter is 7, her son is 5. So this is pretty recent history. And if we're experiencing the things that we did experience in both of those locations, it shows that there are still problems that are experienced here. And at what level are they really worse for women who don't look like us? But there are also cities here in America that are doing the things that can show us a path forward. So how do we extract that model and say, okay, how do we put that here in Hampton Roads?
Dr. Newby Alexander, were you going to chime in, or should I?
I
go ahead?
wanted to encourage you to talk.
Okay, thank you. So as everyone has said, thank you so much for inviting me to participate in this. And I think this is a great segue into some of what I was going to talk about. So public health emerged actually over 100 years ago. And, you're focusing on living conditions, you're focusing on prevention, you're focusing, in other words, medical care is not the end all for health and well-being, right? And so about 75 years ago, the first schools of public health formed with the recognition that we need to train public health professionals and other people to address these issues, right? So injury prevention, sanitation, maternal and child health, surveillance, epidemiology, emergency management. So physicians and nurses, they are wonderful. Medicare is wonderful. We need that, but we don't only need that. And so schools of public health and public health programs are training professionals to have a broader view, to look at living conditions, social economic determinants of health, political determinants of health, to analyze our healthcare system and say, hey, where are the weaknesses? So my answer to you, is that one of the answers is, and I don't know whether or not this is borne out by research, and I am an academic, so I would have to look that up. But in North Carolina, the School of Public Health has a maternal and child health department. And when I was there, they had a really strong group of students who were training to be, MPH public health professionals with master's degrees who were focused on being midwives and doulas. And my guess is where you have and are training professionals to go out into communities and say, hey, what do you need? What are your issues? That you're going to be more likely to have advocates to change policies, advocates to change the way, insurance companies reimburse these things. You're going to have more alternatives for how we help people to be healthy and how we address some of these issues. So I don't have a direct personal experience to say, but I do have some experience with seeing how training public health professionals to go beyond medical care can be beneficial for communities.
Thank you. I had a quick follow-up with Mrs. Grayman Rich, and this has to do with the United Order of Tents, because that organization was very involved in midwifery. And so I was hoping that she would, give us a little understanding of that and some of the things that that organization did. And then after that, if Mrs. Cofield would like to kind of insert, her perspective on this, and then we're going to go to our second poll.
Thank you, and I, excuse me, I will. Excuse me. One of the primary challenges for our communities, I believe, is that there might be, and maybe, and there is a lack of clear communication because many African American communities remain unfamiliar with the healthcare role of the midwife and believe the myths that are surrounded by that role. Oh, they don't know how to provide care on a level of that of a physician, which is very, very far from the truth. And as I mentioned earlier, there are several African American midwives that are members of the Association of Certified Midwives. So you want to know how the United Order of Tent fits into this. And let me just give you a very brief spiel of the United Order of Tents. The United Order of Tents, it is a Christian fraternal benevolent organization, and it is managed predominantly by African American women. It was founded by 2 ex-slaves and 2 abolitionists in 1897. It is documented. It is historic. It is when this organization started. And the focus of the organization was to care for the sisters within the organization. Well, in terms of caring for them, they were sick, went into the homes, went in the communities, because again, we had limitations as to what was afforded to us. But that was the focus of the organization. And as the organization continued to grow, the organization then, of course, extended out to the community. So the first community effort of the United Order of Tents was to establish a home, and it was called Rest Haven for adults. This particular home was available and opened in the early 1900s. It closed in 2002. But let me tell you what the organization continued to do. The blessing that we had was that there were HUD grants available. And so this particular organization was afforded 3 HUD grants. And because of that, we were able to assist in the building and the management of 3 housing developments that catered to adults and continues to this day. So the first one was the Bullock McLeod housing for the elderly, and that's in Rocky Mount, North Carolina. There are 48 units that house seniors. The second one was the Harrison Johnson Apartments in Danville, Virginia. There are 41 units that house adults. And then the Annetta Lane Apartments in Norfolk, which house 41 units. These housing units are named after, one is named after the founder of the United Order of Tents, which is Annetta Lane, and the others are named after prominent and significant women who served as presidents of the United Order of Tents. The United Order of Tents, Southern District number 1, is housed in the state of North Carolina, Virginia, South Carolina, Georgia, and our current president is Mrs. Lotus Jackson Gloston. This organization provides educational scholarships for any high school student who is going to a 4-year college or a 2-year community college to better their education and then to bring back to our respective communities that knowledge base that they have. We are an organization, and Ms. Cofield can speak to it as well, that we serve others. And so that's our connection to the community. Can we connect better? As being part of this panelist, I believe that we can. I know that we have several women that are participating in this session today who may have passed childbearing years. That doesn't mean you can't benefit from the knowledge of this session. You can pass this on to those members within your family who are still in childbearing age, to let them know they have options, just like Hillary said, they have options, just like Dr. Richmond said, they have options. But if we don't communicate the community about the different options, they won't know. Thank you.
Thank you so much. I'm sorry. So now we have this next poll on career in health. So if you would just quickly provide us with your answer. Have you ever considered a career in a medical or health field? Yes or no? Not have you pursued one, but have you ever considered a career in medical or health field? Yes or no? And while you all are clicking on that answer, I would like to turn my attention to Dr. Mebane and ask her to explain why Norfolk State University has joined with Eastern Virginia Medical School and Old Dominion University to create a school of public health?
Thank you for that question. So the ONE, which was on the previous slide, is called the One School of Public Health Initiative because there is an equal partnership between Old Dominion University, Norfolk State University, and Eastern Virginia Medical School to form what we hope will be the first school of public health in the state of Virginia. And schools of public health are important because they draw resources to the regions that they're in, and they help build a workforce that is focused on those, on the issues that we've been talking about today. So for example, schools of public health are important because issues of infant mortality, obesity, diabetes, chronic diseases, injury, prevention, and all of those are complex. We know there are genetic components, but we also know there are political components. We know there are economic components. We know there are environmental components to whether or not a person, and more specifically for public health, communities can thrive. And so in order for us to address these disparities we've been talking about, for example, a school of public health would have a Department of Maternal and Child Health. And that would train people to think about the conditions that influence upstream what's happening with women, both, as they prepare to have children and then also as they're caring for children. And then also training people to, again, advocate for policies, to engage in their communities, to conduct research so that we can really understand. And, if we're going to change conditions sometimes in politics, you have to have the evidence, you have to be able to go into the rooms and make the arguments and make the cases for that. So we're preparing people to address issues in the ways that communities need them to be addressed. And so I think part of the reason why Norfolk State is involved is because we know that there are challenges within our Black and Brown communities in this region that need to be addressed. And having an academic public health presence where Norfolk State is a leader will help ensure that we are training public health professionals to work with, not just with, to partner with our communities, to respect the expertise, to respect the different ways that our communities might want to approach these issues. And then again, to generate evidence, to make the case for changes, to help build capacity within our communities to address these issues, public health issues. I think that's one reason why we're involved, because we can have a real impact on training the next generation of professionals to be more culturally competent, to recognize whether they're communicating well or not, when they're engaging with community members or providing services. There are quite a few physicians who get public health degrees in part to add that layer of understanding about the systems and communities that they're working in. And then also, to be realistic, it's an opportunity. Coming out of the pandemic, there's a lot of focus on public health right now. We have dedicated resources from the Commonwealth of Virginia to set up the School of Public Health, and some of those monies have come here to Norfolk State specifically. And so we have an opportunity to build from the ground up using resources and ensure that the professionals that we are training, are the professionals that we need for our community.
Thank you. And I'd like to add an additional plug, and that is, many people don't realize that Hampton Roads has the largest concentration of African Americans than any other area in the Commonwealth of Virginia. And I believe there is a correlation, though there needs to be a study done on that, between the high numbers of C-sections that are performed on African American women, but on the general population. And so, Norfolk State also has the most diverse faculty of any public institution in this Commonwealth. And so that adds a different understanding and perspective. When you are, this is the importance of diversity. When you are surrounded by people who just look like you, but don't look like you, don't have your same background, and do have your same background. When you're surrounded by this collective, your perspective is different. And historically, women have operated in the collective, which is why when women get involved, things happen. And yes, I will say that again. When women get involved, things happen. You give a job to a woman, it's going to get done. and they're not vying for who gets credit. What they want is that whatever it is they're trying to get done, that it get accomplished. And that's why the civil rights movement was successful. Even though everybody points to the men, it was the women who organized, who spearheaded, who even planned the whole objective of that movement. And so I believe that as women really get involved in public health, then the issues that I faced when I had endometriosis for 30 plus years went undiagnosed, and the same treatment that I saw in an article published by a local Black physician in 1912 in the National Medical Association Journal was the same treatment that I got in the early 2000 period. So we're talking almost 100 years later. I got the same treatment that they did on women 100 years prior to that. We need women, especially to be involved, but then surrounding ourselves and integrating men very much in this process so that we can change the way in which we culturally practice these institutionalized issues can move us as a society forward. I'm going to get off of my platform, off of my little soapbox, and we're going to look at the results, Stephanie, of this last poll. So interesting, 76% have at some point in time considered a medical or health field career. So that's very interesting. So I've got a follow-up question for Dr. Mebane. And if we could see that next slide. So Dr. Mebane, why is there a public health crisis for African Americans? And if so, what is that crisis?
Yeah, I mean, that is such a huge question. And I'm glad we're saying it out loud here. I mean, I really thought about this because it's not a crisis, right? I mean, there's a crisis of infant mortality rates, a crisis in obesity. There are mental health, crisis. There are just multiple. And the reason we say that is because we know that the outcomes for African American communities are a lot worse compared to other folks. But now, to me, I almost want to also change that language. It's not just a comparison, it's that we want our communities to be better. That's it, right? We know that there are problems, we want to be better. And so that means some things need to be done. And these are some of the issues that are foremost, because there's research that shows when you talk to officials and you talk to communities, these are the things that bubble up. And so again, obesity, diabetes, mental health resources, and that type of thing. And to be honest, when I was thinking about this, I put structural racism and discrimination as the biggest why. And I encourage folks to look up the American Public Health Association in 2020 declared structural racism as a public health crisis. And they have a document called Structural Racism is a Public Health Crisis, Impacts on the Black Community. And within the last year or so, you've seen lots of communities at the state level, at the local level, as well as professional organizations that are focused on health say the same thing. And I mean, we all know the reasons, right? Because it means that all the structures and systems are set up to discriminate against certain groups of people, including African Americans. And that's related to housing and education and jobs and benefits and all of that. And the result is it impacts our health, and it impacts our access to health services. It impacts our views about health, whether we are more or less likely to even go seek the care that we need, whether we know, as was mentioned, that there are other options. I mean, racism affects all of that. And so that's one of the big whys. And we're in a moment right now where a lot of public health professionals, not a lot, where there are enough of us, I think, as public health professionals and others who are focusing on that, because that is it's multidimensional, it's complex, but it's so serious and impactful, dating all the way back to the history that you talked about, Dr. Nubi Alexander. This is not new, we know this. This is an extension of what we've experienced for hundreds of years. And so if we're gonna try to break that cycle, then we need to have public health professionals who are looking at it from a variety of angles: epidemiology, biostatistics, informatics, health services administration. And so that's one of the whys. And then related to that, I also think, a lack of diversity in medical professionals, but also public health professionals up and down the chain, from community health workers who are trained to go out to the communities, all the way over to surgeons, all the way over with the mix of surgeons. I don't say over, there's no judgment there. It's just we need for every type of position that is engaged in medical care and then prevention healthcare to have diversity of perspectives. We need more women in some of these roles. We need more Black people in some of these roles. We need more LGBTQ people in some of these roles, because if we're going to solve these problems, we have to be open to the best solutions. Again, not ignoring what we already know, going back to the future, right? Let's not ignore, as Ms. Cofield was talking about the home remedies, they're successful because big brands that talk about having ginger and having all of these things. So we know they work because mainstream folks take advantage of the connections to those things to make money, for example. And so those are the whys. I mean, we could have a whole session on the why of this, I think, but those are some of the things that I wanted to mention today.
Thank you so much. That was so informative. Now, talk about going back to the future. We're going to actually go to our next question and ask Mrs. Cofield to kind of go into a little bit of her involvement with midwifery and its importance to African Americans.
Okay, can you hear me? Can you hear me?
Yes, we can.
Can you hear me?
Yes, we can.
The question is explain my involvement in being a midwife. I have never been a midwife. You can hear me correctly. Now I'm a member of the United Order of Tents of Southern District Number 1. I'm with the Virginia Beach chapter. But I have heard so much about the nurses and midwives. My grandmother, Miss Cora Wright Wilson, was a midwife. She was a leader of the United Order of Tents, and she organized the Queens of Prince of Dance and number 501 in 1945. And I started reading about the United Order of Tents, learning more. The United Order of Tents helped not only their sisters, but also others in the community. And as my sister stated, this started with Annetta Lane and Harriet Taylor, who were enslaved ladies. And Sister Lane worked as a nurse on a plantation where she lived. Her passion sparked the idea of starting an organization where she would be able to help people of her own race. This was a time in the United States when gradually was a move from enslavement to freedom. During slavery time, they had a deep knowledge of using herbs. And as I stated earlier, my great-grandmother, who was born in 1861, she was born in the time of slavery. So those things were passed down to her, and she passed those down to us. My grandmother, I would hear her talking about, when I was a little girl, about delivering babies. And I'm thinking, delivering babies. And she would be talking with the other ladies in the community, which is Northwich Duck Road, was called Chinese Corner in Prince William County one time. And so I would listen. And Mr. Roy Reed, my band director from 5th grade till I graduated, said, Margie, my mother and your grandmother, Miss Cora Wilson, delivered babies. They were midwives in Princess Anne County. And my grandmother was born 1897. Now, she said she delivered the babies. She would go there to help the mothers. She would even go to help cook food. She would help to wash diapers. They helped each other. And that's what many of the ladies need today. And the other part of the question is, why do I think this is important? Being a midwife is important because we need trained professionals to support and care for the ladies during pregnancy, and during the time of when they deliver, and even after the birth of the babies. And I think it's important that they continue this even today. And I tell you, in the time I was growing up, the midwives had the same position of elevation as the pastors in the community. They were well respected, and they functioned as far as passing on their knowledge and valuable information they had onto the future generations. And my grandmother said they tried to train some others to be midwives. As I stated, I was not a midwife, but my grandmother was. And they are definitely needed today in order to be able to help others. Today, the midwife's care can be helpful to the mothers, and especially mothers when they come home from the hospital. They need help. first few weeks of their home from the hospital, so that it's definitely needed today. My last question after everyone will be talking about how can we help, but I can wait for that one.
Thank you so much. We're going to go to our final poll. Before we really discuss the barriers keeping African Americans from going into public health. And so I want to ask you, what do you think is the greatest barrier to recruiting more people to going into the health professions? Is it educational costs, do you think? Is it lack of knowledge about the pathways and options in health careers? Is it difficulty or length of training or education needed? Or is it low pay? So you just can only pick one of these, because I know some of you are thinking, oh, it's all of these or two of them. No, just pick one, the one that you think is the greatest barrier, because this is important information. This is part of what scholars need to look at. And of course, Dr. Mebane going into and helping to create our Public Health Institute and school, this could potentially be very important. So what do you think is the greatest barrier to recruiting more people to health professions? And as you're answering that question, we're going to actually go to the next slide and pose this question to Dr. Mebane and Mrs. Grayman-Rich. What are these ongoing challenges or challenging issues facing African Americans in their health, and how are your organizations addressing those challenges, or even what some people perceive as threats? And so I think we have, about 20 more seconds for people to make their selection. And so as you are finishing that up, I'm going to invite Dr. Mebane and Mrs. Grayman-Rich to address that question.
I will yield to Dr. Mebane first. Dr. Mebane.
Okay, thank you. I appreciate. I'm going to be pretty quick because the School of Public Health is one of the answers, but it's not just the School of Public Health, it's also the degree programs that are happening here at Norfolk State. And so I mentioned a couple of the ongoing issues. In my notes, I mentioned mental health disorders, obesity, poverty, right? It's a lack of resources or a lack of access to information and all of those things. Infant mortality rates are particularly high among a lack of cultural competence among our health professionals, our policymakers, people who implement, as well as a lack of information about opportunities. That was, to me, that would have been my vote, I think, for one of the challenges. And what we're doing here at Norfolk State is, again, focusing on academic public health, developing both credit and non-credit opportunities for training. For example, Norfolk State is now the Eastern Virginia Area Health Education Center, AHEC, which is a nationwide program that's funded by HRSA. And one of the charges, both for schools of public health as well as the AHEC, is workforce development. And that's not just for people who want to get degrees. It's for anybody who's interested in health or connected to health in some way. We're going to have programs for high school students and junior high school students to introduce them to all the health professions. We're going to have funding for scholars who are interested. Diversity is one of our top goals. Cultural competency is one of our top goals, but also other types of training for people who might be interested in midwifery, for example, or being a community health worker. And then also as a university, we have professors who are conducting research, as you know, on the trends, epidemiology, and all of that, as well as thinking about service and education and reaching out to our community. So, just focus right now on what Norfolk State is doing in terms of the academic enterprise.
I want to ditto what Dr. Mebane just shared with us. But in connection with that, as she was speaking and sharing public health education, I think that our challenge is, as I mentioned earlier, communication. In that somehow we are missing the mark with implanting, if you will, the various health education and different disciplines that our young people could possibly pursue. So if we could somehow connect with our high schools locally, if Norfolk State would connect with some of the public universities in the state of North Carolina, and go ahead and offer this kind of sessions to our high school students, to our college students who may not be thinking about public health. But public health is in 2022, public health is vital. It's vital, it's vital. So I would think that that would be our ongoing challenges, but it's not challenges that we can't address. Thank you.
Thank you. We're going to actually jump to our final question in lieu of our time constraints. Stephanie, can you give us the results of the last poll before we ask Mrs. Cofield? So this is interesting. It's kind of tight with that second choice. Educational cost seems to be the biggest barrier in the minds of our guests here. Follow very close, well, not close, very closely, but somewhat, lack of knowledge about the pathways. So what this is telling us is that costs, educational costs seem to be in the minds of the people answering that poll, one of the biggest obstacles. I want to finish up our Q&A, our panel discussion with the last question going to Ms. Cofield. What efforts can come from community advocates to promote health and wellness of African Americans, especially if the issue seems to be cost? And Mrs. Cofield, oh, there you, I think she's coming in.
Okay. The question that I have is, what efforts can come from community advocates to promote the health and wellness of African Americans? As I've been reading, the emphasis has been that there's a need for individuals in the health profession who have a common bond and understand the needs of people of color. For example, when Black families are cared for by Black health professionals like midwives, they're better heard, seen, respected, understood, and get their needs met with relatively, direct health assistance at that particular time. And if we, as individuals of color, can figure out ways to serve the community at this time, to learn more general information about being health professionals, becoming midwives. And I looked on the website, there are places that we can look in order to get additional information. I looked at a site called Midwives Alliance of North America. And there was also an emphasis also that there are scholarships that are available for people to go into that particular profession. And how can we as individuals, advocates, help? We can spread the word, get the word out through social media. We are in fraternities and sororities. Put that on the docket for the Pan-Hellenic Council, and they can give it out to members in their sorority and give it to others in the community. Churches would be a big area. Talk about it in our churches. You have the United Order of 10th Southern District #1. You have the Eastern Stars. You have other community groups. Go to those groups and talk about how we can get into the community and convey this information to individuals of color to show that they can be heard. Also, we can support our nearest facilities that deal with midwives and learn more about that. And we can support those groups by, again, going on the website and finding organizations that we can work with to try to make a difference, and probably even work as mentors with some of the professional organizations where we can help people of color. But let people know that we hear them and we are there for them. And people can tell that just by the way you talk with them. They can tell how you treat them when they're in your presence. Become knowledgeable and be there to help. And one of my mottos, again, philosophies, is that use the talents that God has given us and use those talents in order to help others. And the people in the medical profession using their talents in order to help people across all, not just African Americans, but all across all ethnicities. So those are my closing remarks.
Thank you so much. Now, I'm going to just address one question that was in our Q&A from the audience, and that had to do with videos or films that have been produced about healthcare. And I wanted to direct everyone's attention to this website called CHAMP Resources, and this is CHAAMP. It's a scholarly collection of resources on the history of African Americans in medical professions. And in that, it talks about and has a category for films with viewable content, such as Africans in America, A Legacy of Hope, Service, and Leadership. Another film that was made in 1995, Charles Drew, Determined to Succeed. There are some other films that the NIH has done, especially focused on Black History Month observances. One is Tracing the Roots of Black Folk Medicine, a Cultural Anthropological Approach. That was in 2002. Another one on Dr. W. Montague Cobb, who's responsible for recording a lot of the histories of African Americans and African American hospitals that were published in the Journal of the National Medical Association. So there's a whole list of important videos that you can see on that website. So please make sure that you take a look at that. Next slide. I just also wanted you all to know about some of the resources. And so this video is going to be available, and Stephanie's going to talk a little bit about its availability, but these are some of the readings. Of course, I call it the Bible of, really looking at Black healthcare, and that's the 2-volume work done by W. Michael Bird and Linda Clayton, An American Health Dilemma. But there are so many others. The History of the National Medical Association, they have a wide variety of resources on their website. The next slide, Stephanie, and some other readings that you can take a look at. Stephanie Mitchum's African American Folk Healing, Carol Weaver's Medical Revolutionaries, Nathaniel Wesley. He was a Black physician who was very, very prominent in the first, I would say, 60 years of the 20th century, Black hospitals in America. So please take a look at those resources. And Stephanie, can you tell us how people can go back and see a recording of this video, and please share it with your groups?
Yes, so this video will be available. I'll put it up on YouTube as soon as it finishes processing. So usually I can send it out Friday midday. And we will email it to everyone who registered as an attendee. And then the Virginia Beach museums, history museums will also put it on their YouTube channel. And send it out to their mailing list as well. I believe NSU usually puts it on some social media platform, Twitter and Facebook. And then I did also post the link to CHAAMP at CHAAMP@virginia.edu, not CHAAMP.org. Although Dr. Newby Alexander would like that one because it's a Malamute rescue, not the African American medical professionals link. So I apologize. I grabbed the wrong line when I looked up the link. It was right above the one I was actually looking for. So yes, so we will have these available to you all, and then we'll get them in an email. And then Miss Graham Rich, or Mrs. Grayman Rich, is also going to send out contact info. We'll send it with the video link to the United Order of Tents. Their website is unitedorderoftents.org. So if you want to get involved or see the resources that her and Ms. Cofield's organization can help to provide, you can get in touch with your local chapter. Since it looks like from the chat, we have people from Michigan, Virginia Beach, elsewhere in the state of Virginia, and Ohio. So all over the country.
Thank you so much, Stephanie. And on behalf of our initiative, our joint initiative, I would like to thank our wonderful panelists for their work, their support. Mrs. Beverly Grayman Rich, Mrs. Margie Cofield, and of course, Dr. Felicia Mebane. Thank you, thank you, thank you for your participation in this exciting webinar. And now I'm going to hand it back to Hillary Plate.
Well, thank you so much, Dr. Newby Alexander. I just want to say thank you to everyone on the panel. Every time I have an opportunity to work with all of you, Dr. Richmond, Dr. Mebane, Dr. Newby Alexander, Margie, and Ms. Grayman Rich, every single time it makes me want to sign up and come go to school at NSU. I just want to come back to school all over again. I want to go to NSU. It's just such an honor to be surrounded by you and to learn from the wealth of knowledge that you bring to these panels. So thank you so much. I do want to ask Dr. Mebane really quickly, how do our viewers stay tuned and pay attention to what's happening with the School of Public Health and the One Initiative? Because I'm very excited by this. I mean, it would make me want to come back to school, and you know, I don't know that you want me at your bedside when you're in medical need, but the fact that you're approaching it from such a holistic and person-centered approach is really exciting to me. So how do we follow the growth of the School of Public Health?
So it is an initiative right now, just to be clear, because we have to do accreditations and approvals, but you can follow at nsu.edu/public health or public-health. That's the page on the NSU website that's focusing on the NSU initiative. And then as the School of Public Health becomes more official, that information will be posted, or links to that information would be posted there.
Wonderful. Thank you so much. You see, I'm looking down to the side. I've got like 5 pages of notes from today's conversation. But I want to thank everyone for participating. And I want to remind everyone that our 4th and final episode for this series, this year's series, will be December 15th. And it is going to be a special episode for the season of unwrapping gifts. And we're going to unwrap myth and suspicion around Black health and wellness, and how African Americans are encountering healthcare and how healthcare is encountering African Americans. So I'm very excited about that one. We'll have some posts on social media and a press release in early December letting you know who some of those panelists are going to be. But please put a hold on your calendar for noon on December 15th. We'll be back with the wonderful Dr. Newby Alexander and Dr. Richmond running the Zoom conversation. And then hopefully we'll be renewing our quarterly panels for next year and talking about next year's national theme, but we'll save that teaser for the December 15th edition. I want to thank everyone for joining us. Please stay tuned for the YouTube links to the video. As Dr. Richmond said, they'll be up in a few days. Have a wonderful afternoon. Thank you.